Good morning, everyone. My name is Sarah Hunstead. I'm a paediatric nurse, mum of two, and founder of CPR Kids. And today I am joined by paediatrician Dr. Deb Levy, and we are going to be talking all about RSV and bronchiolitis in babies. Now, this is something that, as we're recording this live right now on Facebook, that is certainly a hot topic on the socials amongst lots and lots of parents at the moment. So that's why we thought we will bring you some good evidence-based information. You have the opportunity to ask us lots of questions as well, only as long as you are tuning in live though. But if you can't tune in live and you're watching this recording, then what we encourage you to do is please don't hesitate to reach out to any of the medical advice lines or your GP or your paediatrician for some advice. So before I go any further, Deb, can you please introduce yourself?
Great. Thanks, Sarah. Hi, yep, I'm Dr. Deb, and I'm a holistic pediatrician. I have just returned to my home base, which is Sydney, after a year in Canada, and I'm kind of in between homes at the moment, so I'm coming live from the Meriton. Exactly. So, and yep. So, I mean, basically, you know what Sarah said. Today, we're going to do a deep dive into RSV. And hopefully answer all your questions. Feel free to type questions in the comments box, and we'll address them later. Obviously, I can't give you personal medical advice, but hopefully I can give you some really helpful information today. Okay.
The other thing that we want you to do as well is that if you could please, just in the comments below, just tag anyone who you think will benefit from this information too, because we really want this good evidence-based information out there, because it can be really scary when you type something into Google and then all of this stuff comes up and you're like, whoa, okay, this is, pretty intense. So, and you don't know what's factual and what's not. It can be really, really hard. So we aim to be that factual stuff, because I
exactly right. What you need to know is kind of the way that I look at it. Yeah.
Thank you.
Okay, so what you need to know about RSV. First of all, what is RSV? RSV.
Tell us what it stands for.
Exactly, RSV. 3 letters that stand for Respiratory Syncytial Virus, and essentially it's just the name of a virus. And it happens to be one of the most common causes of a cold, snotty nose, cough, and in younger children also bronchiolitis. So, in the older children, so let's say you're old, 2 years and up, or in us, we typically get a cold, snotty nose, maybe a little bit of a cough with that. With younger children, however, and the younger they are, the more susceptible they are to developing, what I'm going to talk about now, they are more likely to get something called bronchiolitis. And what is bronchiolitis? It's essentially an infection or inflammation of the lungs. So if you've listened to any of my other lives, I often talk about the lungs anatomically, like looking at the anatomy of the lungs as an upside down tree, with the tree trunk being the big windpipe up here, and then all your little branches being, the smaller branches and the leaves. And it's all those little branches that get affected by RSV. And what does that mean? It essentially means that your child can develop problems with their breathing. Before we get to that, I think I'll just go, kind of from the top down. I think it's maybe a good way to look at it. But, what symptoms will your child have? How do you suspect your child may have it? Well, as I said, the first thing, it's a common cold. So a snotty nose. They could have a fever. They could be a bit unwell with it as well. Down a little bit, they could have a cough. This could just be an intermittent, non-serious cough that can just be from the snotty nose itself. But in the younger children, that cough may become more persistent and more suggestive of bronchiolitis. The other thing that bronchiolitis causes is wheezing. Just, that same wheezing that you get in asthma, which is that musical sound as your child breathes out. And that's because those little airways are infected, inflamed, and swollen, and it makes it harder for the air to move, as your child is breathing. Mm-hmm. If your child has bronchiolitis and that breathing difficulty progresses, 2 things happen. One, it could make feeding difficult. And this is especially the case, obviously, with smaller babies, breastfeeding or bottle feeding. And then the other point is that could actually cause respiratory distress. And, again, I've spoken about this before, but I will just recap the signs of respiratory distress so that you're aware of what they are. And it's a little bit dependent on the age of your child, but essentially respiratory distress is a label for a collection of symptoms that show us as clinicians that your child is struggling with their breathing. So they could be doing things like flaring their nostrils, like that.
Yes.
Yeah. They could be making a grunting noise with their breathing, which is like they could be head bobbing, especially with the younger children, with their breathing. They use more muscles to breathe, and then they get what's called a tracheal tug or recessions that you see. Yep, Sarah's doing a really great impression there. Also above the clavicle, your collarbone here. And then you can also actually see their breathing. They either start to breathe really rapidly or really labored breathing as well. And you can see the muscles working, either sucking in underneath the rib cage or between the ribs. So that's at the extreme, when your child has developed respiratory distress.
And what I was saying here too is, well, first of all, this happened to one of our educators, our nurse educators. Her son actually ended up with a nice, good going tracheal tug the other day. It's on our Instagram. Go and have a look at it. You'll be able to see it there. But not only that, this is where part of looking at your child is really, really important, and that you actually take their top off or their onesie open. You're not just looking at them up here and having them all bundled up. If you're worried about your child's breathing, you are unwrapping them. You are taking their clothes off and you are having a look at all over here to see how they're breathing.
100%, yeah. So that's all that respiratory distress. What I touched on was also, that feeding can become difficult, and that often is one of the main problems, and it can be quite tricky if your baby is breastfeeding. And the tip that I would usually give is to make sure that your baby's having regular wet nappies. And at least 6 in a day would be a good indicator that your child is hydrated. And if they're not managing a very long feed, obviously you definitely need to go and see your doctor. But also the other thing that we often would suggest is shorter feeds more frequently, so they're getting that same volume, but just over less effort for them really to get it. The other thing you can also try. Pardon?
Because they can tire very quickly.
Exactly. Yeah. And the other thing, and this goes for any cold, any snuffly noses, you can always give them some saline spray prior to a feed. So these are little tips that you can start or use while you're waiting to see your doctor for a proper review. Because when babies have bronchiolitis, really the two main indicators for us to admit them to hospital would be, are they feeding okay? And are they working really hard to breathe and needing oxygen? So, those are really the two main camps. And often you'll find that babies will be admitted to hospital. And yes, they may be working a little bit harder their breathing, but it's okay. And maybe they don't need oxygen. They've had their oxygen saturations measured, but they're really not managing with their feeding. And sometimes babies will need a nasogastric tube for that, which is a thin feeding tube that goes in through their nose and down into their tummies, just to help them during that recovery period. Because really, as with the majority of viruses, I almost said any, but there are a few, as with the majority of viruses, there's no specific cure. There's no specific medicine. There's no antibiotic that'll help. And often it's just time, and supporting them through that period when they're worse,
Exactly.
And I think, unless you want to add anything, Sarah, but I think that, that kind of leads us into, well, what is the time period, and, what can I expect, if my child picks it up?
Yeah, exactly. I do think one of the important things that we need to really make sure that everybody who's watching, and please tell everybody you know about this, that if things change, so if you go to hospital, you're discharged home, you go home, your baby's not getting better, things are getting worse, go back again. Okay.
100%.
And Deb will go into, I'm presuming you go into now about how things progress, because certainly there are certain times, this illness peaks. And so that's why it's really important that if things change or they're not getting better, you're not afraid to go back. and seek help. It's really, really important. We want you to do this because what we want you to remember is that you are an integral part of the team that's looking after your child. So it's your doctors, it's your nurse, it's all of that kind of stuff. And we've got to work as a team, and you know your child better than anyone. Really.
100%. Yeah. Excellent, Sarah. Thank you for that. So I guess going on to, well, what is the natural course of this illness? What I'm going to start off with is, how do children get it? And children get it through contact with someone else who's got it.
Mm-hmm.
The tricky thing is that it's spread by droplets. So if someone coughs, sneezes, it's also spread by direct contact.
Mm-hmm.
You know, you may have heard of the danger of kissing babies, and this is one way that it's transferred. And also by contact, you know, on toys and things. So if a child has it and has done a big cough splutter and it goes onto a toy, that can actually last for a couple of hours, you know, which is why it's so important to do lots and lots of hand washing, and, you know, also keep children away from other children if they're unwell. The tricky thing is that it can actually be quite long. You know, the infectivity period is around about 10 days. And so it can be tricky because someone may not realize that they have it or that their child has it before.
If you're the only parent at home and you've got a 3-year-old and a 6-month-old and maybe a 7-year-old as well, it's impossible to keep them apart. You can't physically do a lot of the time. So you just got to do the best. Yeah.
Yeah, exactly. And okay, so that's about the how contagious it is, and it's highly contagious. The next point is, well, what is the natural progression? So if your child gets it, you know, as I've said, older children, they'll just get your typical cold. We will just get your typical cold. Younger children will go through quite a particular pattern, a natural history, and they'll get the snotty nose, a little bit of a cough, and then around about that day 3 to 5 period of the illness is when we find that it peaks in terms of severity. So, for example, you know, and just touching again on what Sarah said earlier, if you've got a little baby who's got a snotty nose and a cough, and, you know, you take them to your doctor on, you know, let's say day 2 or 3 of the illness, and they go, oh yeah, you know, their chest is fine, everything's fine, you know, it's fine to go home. What is important is that don't just go, well, everything's fine, it's going to be fine, because what we do expect is for things to get worse. So it is natural for, you know, normal for things to get worse with RSV before they then get better.
Yeah.
And how long they stay unwell for, it's kind of, again, there's a range, and, you know, we look at like the 1 to 2 week period that they're going to be unwell for, but that cough that they have can actually last for a lot longer. But as long as they're not having difficulty with their feeding or difficulty with their breathing or any other serious symptoms or ongoing high fevers, usually it's just a case of, you know, after they've gone through that peak, then just monitoring them.
Yep. Fantastic. Yep.
Yeah.
And I think that can happen as well is that they can get unwell quite quickly too.
Yeah.
And that's up. I'm actually going to take the opportunity to do a little bit of not a mummy confession, because it's not anything that I've ever really hidden, but just a quick story just will show how quickly they do get sick. My oldest child had a lot of wheezy episodes. She had bronchiolitis a few times and went on to have what they call the preschool wheeze and so on. But on the second episode where she actually had bronchiolitis, for us it was about day 3. I'd taken her to the doctor. She'd been seen. We knew that, you know, I'm a nurse. I deal with this, you know, all the time. And I knew that we were to be watching her. And in the morning, she fared okay, wasn't too bad, certainly wasn't her normal self, was wheezy. And then over the progression of a few hours, she became really quite unwell. I noticed that her work and breathing was increasing. And so I thought, okay, I'm going to take her to the hospital. I didn't feel that I needed to call an ambulance. She had increased, you know, she was breathing, but she certainly wasn't in severe distress. I popped her in the car safely, started driving to the hospital, was checking on her in the rear vision mirror. And what I did notice was that all of a sudden she became really quiet. And that I went, oh, hang on, what's going on here? And so I stopped the car and I went around, and she was changing colour. And so I immediately called an ambulance, didn't try and rush her off to the hospital or anything like that, because that would be a really silly thing to do. It's much better to be able to have help come to you. So did that, and she was admitted to hospital with bronchiolitis. But very quickly, she became quite sick. And so what the doctor said to me was that they thought that she had what we call a mucus plug that was, kind of.
I was about to say that's what it sounds like, yeah.
Because she picked up after I'd picked her up out of her car seat and so on. And her colour came back. But I was still not going to pop her back in the car seat and drive her to the hospital. Not at all. So what I'm trying to illustrate with that story is that things can change quickly. Keep looking at your child. Keep looking at your child, and if your child is showing those signs of severe respiratory distress, particularly if they're having a colour change and all those sorts of things that we have done a video on, then please don't hesitate to call an ambulance as well. Okay.
Yeah, and just to explain what the mucus plug is for listeners, snot is snot and mucus is snot, so it's the same thing. But the plugs can actually plug up areas of the lung. And that can cause an acute deterioration, which is exactly what Sarah just described. And if that stays blocked off, that can actually predispose again to secondary bacterial pneumonia. So, this is nothing for you to be aware of other than to know it exists, to hopefully give you a little bit of understanding if your child is unfortunate enough to experience it. And also just to be aware, exactly as Sarah said, that children can deteriorate when they have bronchiolitis.
Yeah, absolutely. So that's all I was trying to illustrate with that story, is that just keep looking at your child. Yeah, just looking at them.
And, sorry. The other thing I was just going to mention is that winter is the season for this. So it's not surprising that there are many mums out there at the moment with children. And I see someone's already commented that their son has had it for the last week.
Yep.
So it's very common. Yeah. And you're right, it can be totally terrible. It can be very mild. It's just the luck of the draw. And again, the younger the child, the younger your child is, the more susceptible they are to becoming more unwell.
Yeah.
And if you've had it once, you can have it again and again and again. You develop a degree of immunity that does not last long. I know I often get asked that.
Right. Yes. So that was one of the questions that I was going to ask you. So thank you for clarifying that. If anybody has any questions, now is the time to start typing them into the comments below. So please do that. But we were actually, we had some questions this week in our DMs, which I would like to ask you now, if that's okay. Okay. So one of them that I think you have already touched on, and that was, is there anything that you can do to prevent RSV? So just summarising what you said then would be great, just so we can, with the hand washing and the avoiding the snotty kisses, is there anything else that we can do to be preventing RSV?
So it's exactly the same advice for preventing any kind of infectious illness. It is avoiding people who are unwell, asking people who are unwell to avoid you, not letting lots of people kiss your child, and then obviously depending on the age, either you washing your hands a lot, your child washing their hands a lot, teaching them how to sneeze and cough properly, ideally into a tissue or throw away, or if that's not available, into the corner. Of your elbow, and then not sending them to daycare or school when they are unwell. And I'm just going to mention something that I know we've done before, but I also just read it on social media recently. A snotty nose may or may not be infectious, but in this context of being unwell, clear snot and green snot can be equally infectious. Clear snot does not mean that your child is not infectious. Have I said that clearly?
Yes.
But does that answer your question? So, you can't avoid it. It's around. It's always going to be around. It's about trying to minimize the risk.
Absolutely. And so Nicole has asked us to extend a little bit on the kissing. Now, Deb, you summarised this beautifully in one of the last. See, I'm pointing back over my shoulder. I'm not sure I'm doing. It's there. It's over there.
Yeah, exactly. Right.
There's the video we did.
Like a matrix.
Exactly. I'd love to be able to just, here you go. Here's the video we did.
Yeah.
So we did a video the other day, a couple of weeks ago, that was talking about, and you were talking about kissing and babies. And one of the things that I loved was that it's real, obviously siblings around when they're actively unwell, trying not to get them to kiss at all. But what I loved is when you were saying your oldest daughter just had a bit of a cold, and you had your youngest daughter, and you got her just to kiss her on the back of the head, because you didn't
back of the head or the toes.
Yeah, or
like
the toes.
Yeah.
Avoiding the
hands,
fingers.
not hands. Yeah, because babies always have their hands in their mouth. And usually they're at around about that 9 months when they start sucking their toes. But yeah, on the top of the back of the head, because I think that's very low risk. Because I think that the sibling relationship is so important. So that's why I don't want to ever say no, don't go anywhere near.
Yeah.
So, and I mean, I think sorry, Sarah, I think when children are unwell, they don't really feel like being around other kids anyway. So.
No, exactly. And I think, it's about thinking as well. Is it somebody who is, is it you or your partner and people in the household, that of course you're not going to kiss your baby on the face when you're actively unwell. Of course you're not going to be doing that. But,
carry on.
If you go to great Aunt Mabel's house, who's meeting your baby for the first time, and then she's, showering your baby with kisses over the face, that's something that, what's your opinion on that, Deb?
I think that for younger children, it's best to avoid it.
Yeah.
Again, you can do the top of the head, especially for the first few months. Just let them build a bit of their immunity. The other thing I just wanted to mention as well, breastfeeding can give a degree of protection, but obviously it's not a full protection. And then the other thing that can predispose or make them worse, there you go, is smoking. So if anyone in the house smokes, now's when you have children, it's the best time to quit, because that should be a great motivation for you, because it worsens all respiratory conditions plus other conditions as well. So don't be around anyone who smokes, and it lingers on clothes too. So if that great auntie, is the smoker, then I think it's another reason to say, hang on, maybe there's other things we can do to convey her affection.
Yep, absolutely. I think that can be a hard thing. One of the people who works at CPR Kids, she had this fantastic thing that she put on her pram, because she found that when she would go out and walk with her newborn, getting out into the fresh air, which is so important, that she would have strangers come up and they would literally shove their heads into the pram and get like that far away from the newborn. And she would have to she said it was mainly older ladies who just
the best of intentions, right?
Best of intentions, and so she had this little plaque that sat on her pram, and that said, "Your germs are too big for me. Please smile, but don't touch." It wasn't
touch me, maybe
like that, but it was beautiful, and it really helped with that, because people would see that and go, oh, okay, so it's not, it kind of stopped the awkwardness as such, which I think is a good thing.
Good.
Yeah. Okay. All right, we got lots more questions. Okay, here we go. Okay, now Sophia has asked, are blood tests recommended to ensure there isn't a secondary bacterial infection that requires antibiotics?
Okay, hi Sophia. No is the bottom line, unless your child has clinical signs of a pneumonia or of a bacterial infection, and that will be assessed by your doctor. We don't preemptively do blood tests to make sure there isn't one. We need to have a high, level of suspicion that there is one there. And even then we sometimes don't. We just treat. Yeah.
Okay, excellent. All right. Now, let's see. Sarah has asked, is RSV something that parents should convey to a daycare? The centre then is tracked, just like they do with gastro, and so on. What do you think about this? I actually don't know if there is a policy on this. Particularly.
It's not what's called a notifiable disease. And a notifiable disease is one that there's a legal obligation from healthcare providers and daycare centres to notify, like New South Wales Health. But so the answer is really no. And the majority of cases, we don't even know it's RSV. So children who have a runny nose and a bit of a cough, we don't routinely test them. And even young children who we think have bronchiolitis, we don't always test them, depending on where they're being seen. In the hospital setting, yes, we do, because we have the facilities. and it helps us make decisions should they deteriorate. But so the answer with that is no, but I certainly would adhere to the infection, protocol of your daycare center.
Yeah, absolutely. Excellent. Okay. Now, Jade has asked, our GP suggested a puffer, so 19 months old, thank you for clarifying that, to accept the mask. Any tips? Okay, we tried monkey see, monkey do, but he won't have a bar of it. Yeah.
Okay. Firstly, whether or not puffers help depends on the age of your child and the clinical response. So bronchiolitis doesn't always respond to Ventolin, especially in younger children. And certainly in under 12 months. It doesn't mean we sometimes don't try it, but your 19-month-old may or may not respond. And I guess your GP has tested that by examining, giving the puffers in rooms, and then re-examining. And that's certainly how I would assess. The monkey, and Sarah, I think we'd actually spoken about doing a session on this.
Yeah,
so maybe
why don't we do you want to do this next week?
Yeah.
Oh, I'm just getting a mannequin. Don't mind me. Oh, here's one I produced.
Yeah. I mean, why don't we just do a proper session on this?
Yep. Okay. Why don't we do next week? Why don't we do tips and tricks on giving medication, including puffers, to children? Yeah. Why don't we do that?
Because then we can do it with, and we'll have everything prepped. So Jade, if you don't mind tuning in or watching the replay from next week, we'll answer your question properly then, because we can't go into it in great detail now.
That's right. A quick tip for you when you're giving it, having him or her on your lap, chin in like this, and being able to do this. There's other ways as well. We'll go into that next week.
Yeah.
Well, there we go. I'll put my baby down. Okay. All right. And, okay, what else have we got? Okay.
Got one from Steph about RSV droplet or
airborne. There we go. Found it. Thank you.
Okay. It's droplet transmission, so it lives in the sputum more than anything else. So I mean, airborne, yes, it can be airborne if someone's coughed into the air. So yeah, I think that does that answer it, Sarah?
Yep, I think it does. Yep.
I think is what I'm saying to you.
Yeah, very good. Okay. All right. So Lisa has got a question. And just before we go into this, it's really what we can't do is specific medical advice. And so that's one of the things that we can't do. So Lisa, unfortunately, what we'd probably recommend here, if your little one has had, a cough, you've seen the GP and having nosebleeds and so on, well, the best thing that we can do is actually get you to go back to your GP or your paediatrician to be able to discuss that, okay? Because it just, unfortunately, without being able to see your child and know all of the other ins and outs that Deb needs to know, it's very, very hard to be able to give specific medical advice. Okay?
I'll just mention the nosebleed thing now. We'll address that.
Yeah, go for it.
So children have nosebleeds for lots of reasons. The most common reason is this, picking their nose. And then another common reason is the common cold, because what it does is it causes inflammation of the lining of the nose, which then becomes more delicate, and they just have a little nosebleed because the vessels on the inside of the nose, like the septum, the middle part, are very, very close to the surface and very fragile. So it's very, very common. And we typically don't investigate it further unless your child has ongoing repetitive severe nosebleeds or anything else that we find on examination that worries us.
Yep, fantastic. All right, very good. Okay, now Steph has asked a question. Now, I don't know the answer to this, but I'm sure we could.
It can last up to a couple of hours.
Okay, there we go. See, you're the expert in this. Excellent. Okay.
But not days. Yeah, a couple of hours. I'm not sure the exact, but it's a couple of hours.
All right, very good. So what we are going to do is I'll also put in the comments now too the Royal Children's Hospital Melbourne fact sheet on bronchiolitis. This is available in about 10 different languages as well. So the link that I put on there will take you not only to the English version but also to the fact sheet in I think it's 10 different languages too. So you will be able to share that with family and friends who who need that. So please read it, send it around. It's good, evidence-based, factual information. And what we would love you to do is come and join us next week when we give you all of the paediatrician and paediatric nurse tips and tricks on how to give medications and do other things to kids, like measure temperature and stuff like that. Okay, so because we've done a fair bit of it over our career, wouldn't you say, Deb?
I would say so.
Yep. No.
Fantastic.
Definitely. Okay, so I think that's
it. Yeah.
We'll see you later. Thanks, everyone.
Have a great day. Bye.